So my name's James. I'm the president of the Emergency Medicine Society. So this is the first session actually of a series on the basics of emergency medicine. So each week we'll just cover a different topic and all the emergencies to do with that topic. It might be things that you see in ED, or it might be kind of emergencies within a particular specialty. So it will relate quite closely to the different placements and things that you're doing. So today we've got one on chest pain from Sam, and on Thursday evening at 7 as well, we've got one on neurological emergencies. So that would be really useful, especially for anyone in fourth year doing neuro this year as well. So I'll hand over to Sam to get started on this session. Okay.
Yeah, okay. Hi everyone. I'm Sam. I'm the education officer on the society. Could I just check, can people use the chat, or is it muted at the moment? Yeah, good. Okay, and can you see the slides and hear me okay? Okay. So yeah, I'll get started on this. I'll try ask some questions throughout it. So if people do want to contribute, please do write it in the chat or turn on your mic if you want to. I know people don't normally like to do that, but whatever. I'll try and make it as interactive as I can. So yeah, so this is basically an introduction to chest pain. Sort of, I tried to simplify it down to the main presentations and investigations and management. So initially, if someone comes in to the emergency department or the hospital complaining of chest pain, the first thing that needs to be done is a history needs to be taken from them. So there's a few different sort of ways you can. I like to use Squitas for it. Some people like to use Socrates. But for this presentation, I've done it as Squitas. So to start off with the S, what sort of things would you be asking about the site of pain if someone came in with it? If you'd like to, yeah, put any ideas in the chat. Yeah, so radiation, yeah, that's quite a big point of it, especially with cardiac like pain, because that can often radiate. And yeah, sort of ask them where the pain actually is and ask them to point to it. Yeah. And then in terms of Q, the quality, what sort of pain would you try ask about? Sort of what would someone describe the pain as? Yeah, good. So crushing, sharp. Sometimes people say sort of a tearing pain, maybe a burning pain. And then intensity. So ask them how bad that pain is. Yeah, like someone sitting on their chest. So tightness, anything like that. So for timing, what sort of things would you ask someone coming in? Yeah, so that's good. So what happened when the pain came on? So did anything trigger it? Were you doing anything specific? Did it suddenly wake you up? That sort of thing. And along with that, you'd ask about sort of if it was sudden onset, if it was gradual onset, and then ask if it's been progressive, if it's been intermittent, if it sort of stayed the same the whole time. So you're just trying to get a history of the pain, sort of when it's come on and how it's changed. And then as I do A and R, so sort of what makes the pain better and what makes the pain worse. So normally on about stuff making it worse, I'd ask about sort of exercise, whether that makes it work. I'd again, yeah, also ask about position. So is it worse when lying down? Is it worse when standing up? Is it worse when breathing in and out? And then for relieving sort of factors, I'd probably ask about pain relief and whether that's helped, or maybe if it comes on with exercise, does resting then relieve that pain? And then for the S, just ask about any sort of other symptoms that you think could be related. So if, for example, it was the respiratory system, I'd try ask about shortness of breath, any coughs, any sputum production, that sort of thing. So that's sort of a brief overview of asking about the sort of history of that chest pain. And then what's also important with that is the past medical history from the patient. So that could be their past history of any significant conditions, so hypertension, diabetes. It could be a family condition, again, such as heart attacks and cardiovascular disease, which has happened before in the family. And you'd also want to ask about any risk factors that could be relevant, such as high cholesterol, again, yeah, obesity, alcohol use, smoking, anything like that. So, yeah, that's sort of a brief overview of a history if someone did come in with chest pain. So, once you've done that, onto the examination. So, with chest pain, sort of the two main systems I guess you'd be thinking about would be the respiratory system and your cardiovascular system with the heart. So if we start off with the cardiovascular system, what sort of examinations do you think would be relevant to do for someone? Mm-hmm. If you'd like to, yeah. So put any suggestions for sort of a cardiovascular assessment you'd sort of want to look for on. Yeah, there we go. So suddenly can see. Yeah, so heart sounds, that's important. Blood pressure, so looking if there's any signs of shock, if that's dropped. Yeah, pulse, that's good. So feel rate and rhythm. So do they have AFib or anything like that? Cap refill again. That's really good for checking if sort of they're in shock at all, and whether everything's been perfused. So yeah, you've got most of those. So on top of that, maybe look at jugular venous pulse to see sort of if there's any increased central venous pressure, and again, the heart rate. Is it fast? Is it slow? So on to pulmonary sort of examinations. What would you be looking for there on someone who came in with chest pain? Yep. So what's coming through? Yep, wheezing. So any sort of noises to do with it. So wheezing on expiration, maybe stridor on inspiration. That would be, and then good chest expansion. Thing for that, obviously, auscultating the chest, percussing the chest to sort of see if there's any fluid or any increased air in there. And tracheal deviation, that's a good one. They always forget about. But so if there's, for example, a tension pneumothorax or something, that can shift the trachea across, which is important to look at. So again, just put a few of them there, which you've all got, which is great. So on to the sort of types of chest pain that people will normally present with. So you've got cardiac and pleuritic. So if we start with cardiac, how would someone presenting with that sort of pain describe it, do you think? Yep. So central crushing pain is sort of the normal way people will describe it. Or people say it's quite heavy, like basically like there's a band being sort of tightened around them. And you said about the radiation as well. That's quite characteristic of cardiac pain. So, as I've said there, so the cardiac pain itself is normally from the visceral nerves. And it's a dull central pain because the brain's less able to localize exactly where it is. And you normally get the referred pain with it, which is often described going to the shoulder or the jaw, because the nerves which are flowing back to your central nervous system sort of follow up and link around those areas, which is why it can radiate up there. And as someone said, made worse by exercise. That's normally the case with cardiac pain. And I should have put a note on that as well. It's normally then relieved by resting after that, especially with things such as stable angina. So on to pleuritic pain, which is more somatic. It's somatic nerves which would be innervating that. What sort of pain would someone experiencing pleuritic chest pain describe it as? Yeah, so it's going to be more described as sharp because it's your somatic nervous system. It can localize that pain a lot more. And yeah, as I said, lateral, often it can be, but if it's something in the middle of your chest still that's not to do with the heart, you could still get that sharp pain centrally. So it could be something to do with your esophagus or your cartilage. That'd be felt central, for example. And yeah, positional movement and breathing normally affects it because a lot of the time it will be the pleura that's inflamed. So any sort of chest movement, which includes breathing and irritating that lining, is gonna cause the pain to get worse. Yeah, that's good. So if you thought it was a cardiac issue, so they came in and it was that deep crushing pain which was radiating, what are some of the investigations that you'd get done initially? ECG, yep, good. Troponins, yep, both important investigations you'd start with. So, yep, and chest X-ray, that's true. Yep. So start with the ECG. So you do a 12 lead ECG on them, and just got an image there to sort of show the different leads and sort of where any defects will show on the ECG depending which part of the heart that's affecting. But I've just put a sort of brief explanation for your main acute coronary syndromes and how they'll show on the ECG. So if there's an ST elevation, that implies there's been a sudden occlusion of one of your coronary arteries, which you'd get in a STEMI. And then an ST depression, that normally implies more of a non-sudden occlusion, such as in a non-STEMI or unstable angina. But again, it can mean other things. And then T-wave inversions are often seen as well, which normally implies there's been an undersupply of blood to the myocardium. So in any of your acute coronary syndromes, you might see the T-wave inversions. And then, yeah, for the troponin tests, so if they come back positive, that normally indicates that there's been necrosis of the myocardium, which would lead you to believe that it was a STEMI or a NSTEMI, because there's actually been necrosis of that tissue because of the lack of blood supply. And if it's negative, it would more indicate it sort of indicates there's been a lack of necrosis there. So in unstable angina, although the clot will break off, you're not going to be getting any prolonged blockage of blood supply. So the part that the myocardium won't actually be necrosing. So it'll come back to negative. Yes, so troponin, I and T. So I just put I/T because those are the two they measure. They'll normally just measure one of them. It sort of depends which trust or hospital you're working at. Some do it with I, some do it with T. But both of them show quite elevated levels once there has been necrosis of the myocardium. They did used to use creatine kinase, but they've sort of stopped using that because that can be raised in a lot of different conditions, not just acute coronary syndromes. And yeah, echocardiogram you could do if you suspected sort of a valvular defect or a defect in the wall. And yeah, I've not put it on there, but a chest X-ray for cardiac, you might see evidence of, you might see some effusions if there's been a large myocardial infarction or something like that. So going over the guidelines that NICE sort of say if you suspect someone does have a STEMI. So they suggest giving 300 milligrams, a big dose of aspirin, as soon as possible. And then, I mean, the main treatment would be to offer them a coronary angiography and a PCI, percutaneous intervention. And they suggest to do that if it's 12 hours, if it's within 12 hours of the onset of that chest pain, and if it can be given within 120 minutes of when fibrinolytics could be given. So before someone's sent to have a PCI done, which, yeah, just to sort of explain that, it's normally they'll go into a peripheral vessel, such as your brachial artery or something like that, and they'll basically go round back to the heart and through the coronary arteries to try and find where they'll see where that blockage is, and they'll try to open that up, normally with the stent or something like that, to try and reperfuse the myocardium that's lost the blood supply as quickly as possible. But prior to any PCI, it's recommended that you give either prasugrel or clopidogrel. You give clopidogrel if another anticoagulant's being taken at that point. And it's also recommended that you give unfractionated heparin. If it doesn't meet that requirement for the intervention, then you'd normally try and use fibrinolytics with unfractionated heparin to get rid of that blockage. And then it's recommended that 60 minutes after that, you do an ECG. And if there's been failed reperfusion, you'd then offer the angiography and a PCI, and you'd probably, again, refer it to more senior in cardiology about the management there. Again, NSTEMI and unstable angina, again, 300 milligrams aspirin, and they also recommend using fondaparinux as well for that. And similarly to a STEMI, it's advised that you offer a coronary angiography and PCI if they're unstable or there's a high risk of a cardiovascular event happening. Again, they advise giving dual therapy of that aspirin given before and either clopidogrel or prasugrel and unfractionated heparin. And if like before, they don't think a PCI is required, they'd often still give dual antiplatelet therapy, to try and stop the recurrence of any clots and try and improve the long-term outcome of it. So that's sort of the cardiac pain side of things. So somatic pain. So in terms of investigations for that, as we'll go through here, so if it's that sharp pain, it's unlikely to be caused by an acute coronary syndrome. It's more likely to be something else. So if someone came in with that somatic pain, what sort of systems and organs do you think could be being affected with that? Yeah, so MSK, yeah, so it could be anything due to, could be the muscles, the cartilage, your ribs, that could be causing it. Your lungs and your pleura, that's probably the most likely source if someone came into the emergency department with that. And then, yeah, GI, so, I mean, you said, yeah, probably not GI, but although, yeah, it's rarer than the others, it could easily be something to do with the esophagus, or maybe something like heartburn. So, yeah, all of those systems. Before you investigate, you've sort of got a list in your mind of all of them, and you're trying to limit it down to what you think it could be. More visceral pain in GI. Yeah, so you again, yeah, GI pain, especially, yeah, that's right. If it's sort of within the esophagus or within the stomach, yeah, that's probably would be more non-localized pain. For example, yeah, gastroesophageal reflux disease, it's quite sort of a dull, you can't really localize it. They describe it as burning, that sort of pain. But again, if there's sort of been any, if there's any potential like ulceration, or sometimes if the esophagus is ruptured, that might present as a more serious, sharp pain a lot of the time. But again, it could be a number of things. So that's the idea of the investigations, to narrow it down and work out what system is causing it. So mentioned all those, just the pericardium as well, that can often present as a sharp pain because that's innervated by the somatic part of your nervous system. And as I've said, the investigations you do are sort of going to be based off the clinical context. So I've just put some like bloods, a chest x-ray or a CT. So if someone came in with chest pain and, for example, a cough and shortness of breath, you're going to be more directed towards sort of a lung issue. And because of that, you're probably going to do a chest x-ray. Whereas if someone comes in with really sharp pain after there's been some sort of trauma or injury, again, you might be thinking potentially it's going to be something to do with the bones or something like that. So it's sort of based off the clinical context that sort of guides sort of which investigations you think are most important to do to begin with. And I mean, bloods you'd normally do for any sort of presentation anyway. So just to put a few of the main emergency scenarios. So if someone came in with sharp pleuritic pain, I'll start with the pulmonary embolism. So how would someone with a PE normally present? Yep. For many of these, yeah. So shortness of breath, chest pain, that they're sort of the main two you can get with it. So there's a pleuritic chest pain, shortness of breath, and a cough. They're sort of the main ones. Sometimes you might get, yeah, hemoptysis. Sometimes people get sort of sweating with that. There's sort of can be lots of different symptoms they present with. So I've just tried to put sort of the main ones. And yeah, put tachycardic as well. A lot of them can present with tachycardia. They may have really low blood pressure as well. So cold peripheries, that sort of thing. And in terms of if you see someone who you might think has a pulmonary embolism, what sort of things in the history are going to suggest it's a pulmonary embolism compared to another cause? So yeah, reduced mobility, recent surgery, using the combined oral contraceptive pill, long haul travel. So those sort of things. So I've put pregnancy in there as well, malignancy. So it's basically anything which is going to cause the blood to be basically more coagulable. So there's a lot of other conditions apart from that, and you're looking at Virchow's triad as to why there's an increased chance of a clot. So anything causing damage to vessels, anything causing increased coagulability, anything causing stasis of the blood, anything causing one of those three things is going to increase the likelihood. And previous DVT, that was the next bit I'd put. So it's always important to examine the cath for evidence of a DVT if you're suspecting a pulmonary embolism. So in the picture below, the person's right leg appears to have a DVT. So it's normally unilateral, red, swollen leg, that's sort of what you're looking for if that's your sign of a DVT. So there's lots of management for PE. So the initial one that's used is the Wells score, which sort of estimates your clinical probability of a PE. So if it scores more than 4, you'd normally admit them to hospital, and if less than 4, you'd try and rule out a PE by offering a D-dimer test, and if that's then positive, you'd likely admit them to hospital. And then once they've been admitted, the main investigation that's done is the CT pulmonary angiography. That's sort of your investigation of choice. And on top of that, you can look at ABGs, which might show hypoxemia or hypercapnia. You can do an ECG. I put the S1, so normally you can get deep S waves in lead 1, and then deep Q waves in lead 3, and inverted T waves in lead 3. But I can't remember, something like 25% of the cases that's evident. So you're more doing that to rule any other cause out, and that's the same with the chest x-ray if you order one. It's to sort of exclude any other causes of that chest pain. And then in terms of treatment, initially supportive, so you're trying to make them hemodynamically stable, whether that's with oxygen or fluids. And NICE advise giving anticoagulants straight away, which they said apixaban is the first line, or low molecular weight heparins, and if required, give fibrinolytics to try and break that clot up. Another sort of emergency cause of that pleuritic chest pain. Got a pneumothorax, which is where you have air in the pleural cavity, which often then compresses the lung, causing that chest pain and causing that shortness of breath. So there's a bit of a diagram there. So you normally have a simple pneumothorax, which is where the air's there, but it can go both ways. So it can enter the pleural cavity, but it can also leave. And then you've got more of the emergency, which is the tension pneumothorax. So that's normally when a valve is created, so air can enter into the pleural cavity, but it can't actually leave it. So the pressure will just build up and build up and build up. So that's going to require immediate treatment if someone does present with that. So I've just sort of your basic symptoms. So the sudden onset pleuritic chest pain, shortness of breath. In terms of what has caused that pneumothorax, it can be following a chest injury, following surgery, following a long-term lung condition, or sometimes it can be completely spontaneous with no prior signs. And it's normally the main sort of group of people that will happen with is they normally say quite young, tall males. They can often present with spontaneous pneumothoraxes. And yeah, on examination, there's going to be normally on the side of the pneumothorax, there'll be reduced breath sounds. There'll be hyper resonance on percussion because you've got an increase in the air that's within that pleural cavity. And if it's a more serious pneumothorax, such as a tension pneumothorax, they may have signs of cyanosis. They may have sort of pallor on the peripheries and signs of shock. So in terms of investigations, what would you say are the main ones that you sort of order for someone if you suspected that they had a pneumothorax? Yeah, so a chest x-ray, that would normally be the initial investigation to try and prove that it is a pneumothorax. Do you know what you'd be looking for on the chest x-ray? So yeah, no lung markings. So yeah, black. So yeah, they're on the side of the pneumothorax. Yeah, so you might be able to see the edge of that lung, and beyond that there would be no lung markings because that's all going to be air. And yeah, you might get depression of the diaphragm and mediastinal shift if it's a high pressure. So if it's a tension pneumothorax, that can sometimes be seen. So you might assess their oxygen levels with an ABG, and yeah, for your chest X-ray. Just put an example there. So that's a left-sided tension pneumothorax. So you can see sort of in the inferior part of the left, the left-hand side, more towards the mediastinum, you can see the border of that lung that's collapsed, and beyond that, there's no lung markings. It's all just, as you said, black. There's no lung markings, and also the mediastinum. So you can see the trachea has been deviated away from the side of the pneumothorax. So that'd be a chest X-ray for a tension pneumothorax on the left. So in terms of management for a pneumothorax, again, there's lots of guidelines, but what would be the main treatment for them? So for a simple and for a tension, how would you normally treat them? Yeah, so you've got aspirate, chest drain, and then nod it. So so if it's a really small, simple pneumothorax and it's not causing any issues, so it might have been picked up incidentally on an X-ray for something else, you might not do anything about it. So initially, because we're talking about an emergency presentation, you try to stabilize the patient before any procedure. So if they're critically unwell, give them oxygen. If it's a minor one, you might not do anything, but it's normally, if it's symptomatic, it's normally indicated to at least aspirate that pneumothorax. If it's a larger pneumothorax or it doesn't improve after the aspiration, that's then when you would do a chest drain, which would be inserted. It's on the diagram, the two blue circles. So that'd be between the fourth or the fifth intercostal space and the mid-axillary line. So that'd be where you'd insert your chest drain. And normally, if it's a tension pneumothorax, it's recommended that you do an emergency needle decompression, which is in the second intercostal space in the midclavicular line, and put out a peri-arrest call for that. So that's normally only if it's a tension pneumothorax. So the patient would be unstable, they'd be deteriorating. So time would be a matter of urgency to get that decompression done. So other pulmonary causes of sort of a sharp chest pain. So any ideas? So costochondritis, got malignancy, pneumonia. So pneumonia. So costochondritis. So on this slide, I've sort of more gone towards your sort of to do with the lungs and the pleura. Costochondritis would cause that sharp pain, but again, that'd be more to do with the cartilage of the ribs than the actual lungs. fusion. Yeah. So yeah, main other one you're thinking is pneumonia. So just a few quick things on that. So if it was pneumonia, they'd often be presenting with signs of infection. So they'd come in with fever. They'd probably have a raised white cell count on the bloods. They'd be complaining of a cough, which would normally be productive with yellow or green sputum. And if you did suspect that someone had pneumonia, that the only way that can be diagnosed is with a chest X-ray, and you'd be looking for a patchy opacification on that chest X-ray to diagnose that pneumonia. And other pulmonary ones I've just put, pleural effusion, atelectasis, so the actual sort of collapsing of the alveoli of the lungs, which can be caused by blockages and tumours, empyema, so pus in the intrapleural space, and malignancy could present with that chest pain. So just another cause of that sharp chest pain, pericarditis. So if someone came in with pericarditis, how do you think they'd explain that chest pain? Pleuritic type chest pain. Yeah, worse when lying back. So sort of different to a lot of the other pleuritic chest pains. Pericarditis is often worse when actually lying down. So people that will often try to sleep with their back up with a few pillows to reduce that pain. So yeah, a sharp retrosternal pain, which is worst on breathing in, and also in the supine position, so lying on their back. So examination wise, people often will have a low fever with it because it can often be caused by infections and there's inflammation there. And on auscultation, you can sometimes hear what they call a pericardial rub, which is meant to sound like basically they describe it as leather rubbing. And in terms of the investigations you do, sort of again with like any heart abnormality to do with it, you'd probably request an ECG. Do you know what signs you might see on an ECG if someone has pericarditis? Yeah, so what they describe as being widespread changes, which they describe as saddle ST elevations. So I don't know if you can see up there. So on that ECG, you can sort of see the ST elevations, but they're widespread. So in all the leads, you can see them, and they're described as saddle shaped. So how you sort of differentiate it from a a STEMI or an NSTEMI, well, more, yeah, STEMI, so an ST elevation and a STEMI, is that they're often on in pericarditis. It has the concave shape to that ST elevation, whereas in a STEMI, it's often more of a convex shape, that ST elevation. So it's more like an arch going like that rather than what they describe as a saddle going like that. And on top of the ECG, you'd probably look at CRP, because that would be indicating inflammation, and you might want to rule out an acute coronary syndrome, so you'd probably do a troponin test along with that, and if it was pericarditis, that should be negative. So apart from that, so management of pericarditis, a lot of the time it can resolve itself, but it's advised that you give non-steroidal anti-inflammatory drugs to reduce that inflammation. And it does require monitoring because there can be complications such as cardiac tamponade, which would then require escalation to someone more senior to deal with. So those were sort of the main causes of chest pain. For some, if sort of your main diagnosis, you'd be looking at if someone came to the emergency department with chest pain. But I've just put a few others. So I've said GORD, so it's more of a burning sensation in the chest, which is worse after eating. And so a lot of the time with your sort of abdominal or GI type pains, people might describe them as coming from the chest when they're actually more towards your epigastrium. Top of that, anything to do with the esophagus, so esophageal spasms can cause pain, but that would also present with normally difficulty swallowing or regurgitation. Could have a rupture of the esophagus, although that's rare, but that would normally present with hemoptysis and hematemesis. And aortic dissection, which is often described as a tearing pain that spreads down the back. But again, that's not a common, it's not really, it doesn't happen much. So that'll be at the back of your mind when trying to work out what's going on. But you're going to be thinking the ones I've mentioned earlier instead. And then other conditions. So I've mentioned costochondritis before. So that's more of a sharp stabbing pain in the front of the chest, which is caused by inflammation of the costal cartilages. If there's any damage, so a fractured or a bruised rib, so that's going to be a strong, sharp pain when breathing in and out and with movement of the chest. But that would normally be on the background of trauma of some sort. Other things, stuff as simple as pulled muscles around the chest area. And then just one for the skin. So shingles, for example, it might present with chest pain, but that would normally be unilateral, and you'd see a macular papular rash on that side in a dermatomal pattern. So yeah, those are just some other differentials that you might consider if someone did come in with chest pain. So yeah, it's quite a brief overview of chest pain because there's a lot of things it could be. So hopefully I've tried to cover sort of the main conditions in the emergency department, sort of your most important ones that you can't really miss. So yeah, hopefully that's been useful. If you've got any questions, please put them in the chat.